Ladies and gentlemen, good afternoon. Thank you for standing by, and welcome to the Strategies for the Implementation of Disability Competent Care. At this time, all lines are in a listen-only mode. Later, there will be an opportunity for your questions. Now, if you do wish to ask a question or need operator assistance today, please press star followed by the 0, and an AT&T operator will assist you. Once again, for questions and operator assistance, please press star followed by the 0. At this time, I'd like to turn the conference over to our host, Mr. Chris Duff. Please go ahead.
Thank you, Tom. On behalf of the Lewin Group, I would like to welcome you all to our webinar series, Strategies for the Implementation of Disability Competent Care. As Tom stated, my name is Chris Duff, and I'm a disability practice and policy consultant working with the Lewin Group. The Medicare and Medicaid Coordination Office at the Centers for Medicaid and Medicare Services has contracted with Lewin to develop technical assistance and actionable tools to support providers in their efforts to deliver more integrated, coordinated care to Medicare and Medicaid enrollees. First, I'd like to introduce you to our platform for this presentation. If your slides are not advancing, please push F5 on your computer keyboard. Please note the icons at the bottom of the screen. The second icon from the right allows you to download the slides for this presentation. The Q&A window is open next to your slides. Please enter any questions you may have regarding the material, and we look forward to discussing them during the Q&A portion of the webinar. This series will consist of 8 webinars running on Wednesdays at this time through June 24th. All the webinars will be recorded and available along with a PDF of the slides at the link in this slide. In 2013, we published a comprehensive disability competent care self-assessment tool describing disability competent care in 3 pillars. First is individualized care coordination provided by an interdisciplinary team. Second is redesigned primary care. And thirdly, flexible long-term services and supports. We have since provided 2 webinar series focusing on specific components of disability competent care. These are all also available at the RIC website. Our previous webinars were all more content-laden with little time available for discussion and Q&A. For this series, we are switching that around with only summary content being provided to allow for discussion as the participants are interested. We would like to solicit your opinion on this series as well as past webinars and implemental resources. Please take the time to complete our survey at the end of the webinar and send us your ideas for future topics and content. Contact information will be listed at the end of the presentation. Beyond the Q&A feature, throughout this webinar you can submit questions. You can submit questions and comments at any time. We will also be using an instant polling strategy to ask specific questions to help guide our presentation. To demonstrate this process, here's the first question. What type of organization are you working within? Are you within a health plan, a AAA or Aging and Disability Resource Center or something along those lines, a consumer or advocacy organization, or other? Please make your choice and submit. We will all be able to see the tabulations of your answers in a little bit. Today's webinar will be presented by Dr. Adam Burrows and myself. Dr. Burrows is currently Medical Director of the Upham's Corner PACE program and a Senior Medical Director of the Senior Care Organization, the Commonwealth Care Alliance, both in Boston, Massachusetts. He is an internist specializing in geriatrics and is a national leader in the development of provider-centered care delivery models focusing on adults with complex health needs. Today, we will present an overarching definition of disability and some background information to inform the need for the disability competent care model. We will describe the shift in attitude and compare the traditional medical model of care with an approach that shares responsibility and accountability with the participant. We will follow that with an overview of the 3 pillars of the DCC model. Before turning the presentation over To Adam, I wanted to review the results of the poll survey. I see the majority of you are with health plans. I'm pleased to see that. It was interesting to note that in our previous webinar series, we tended to have more AAAs and state agencies and advocates. So I think what this is happening is I think the health plans are beginning to kind of see more and more people with disabilities and saying, oh, well, how can we meet their needs? And so I'm really glad that there's such strong attendance in this. I also want to provide you some more context for this training. The Affordable Care Act, commonly known as Obamacare, provides opportunities to integrate care and support for persons with Medicaid and Medicare, and to innovate and rapidly scale promising care models, targeting those with the greatest needs, experience the poorest care, and incur the highest cost. The definition of disability we are using throughout this webinar is this slide. Disability is the consequence of impairment that may be physical, cognitive, mental, sensory, emotional, developmental, or some combination thereof. A disability may be present from birth or occur during a person's life. It is not based on a diagnosis, but on an impairment of function. It's important this be noted. This is a critical component to understand, for the model addresses the functional limitation, not just the medical condition.
Excuse me, Mr. Dye, I just want to let you know it's breaking up there at your location.
Okay, let me see if I can move a little closer. Thank you very much. Living with a disability is a great deal more common than we may think. For many of the disabilities are hidden, and many experience limited access to the community. As this slide represents, they commonly face other challenges beyond functional limitations. In terms of accessing health care, persons with disabilities are more likely to face significant barriers to getting the care and services they need. I think that's especially evident in physician care and so on. As the next slide shows, Medicare and Medicaid enrollees have significantly more services, from nearly twice the emergency visit, increased inpatient and outpatient hospital services, and triple the prescription drug utilization compared to Medicare-only enrollees. While this slide shows slightly increased physician visits, this in actuality represents primarily specialty visits. Studies have shown over and over that reduced access and utilization of primary care and services occurs for dual-eligible enrollees. This slide, the next slide here, looks solely at Medicare and Medicaid enrollees and demonstrates that the most costly 5% of the population represents 41% of the expenditures, while the least costly 5% of the population utilize less than 1% of the expenditures. I think what that shows is a key is looking at the membership that you have and being able to identify who are those people who need a different level of touch and support and care. So before I turn this over to Dr. Burrows, I would like to ask one additional polling question that will hopefully guide his part of the presentation here. The polling question is, what pillar of the DCC model are you most directly involved with? Care coordination, primary care, long-term care services and supports, equal, or none? So if you could submit your answer, Dr. Burrows will review it shortly. Now, Dr. Burrows, I'll hand it over to you. Dr. Burrows?
Thank you, Chris. And good afternoon. As Chris mentioned, I am an internist and a geriatrician, and I work in two integrated care models. I work in the PACE model, Program of All-Inclusive Care for the Elderly, which is a staff model. And I also work as the Senior Medical Director for Commonwealth Care Alliance's Senior Care Options Program. And my role there is primarily bridging our health plan and our clinicians with primary care sites to form a fully collaborative partnership. Next slide, please. So what are the problems that we're trying to address through integrated care? Previous slide, please. Can you just go back one? Thanks. So what are the challenges and the problems with our healthcare system as it's structured in trying to meet the needs of persons with disability? Well, first, care is commonly reactive. In other words, care is punctuated, it's episodic, it's problem-based rather than preventive, preemptive, and continuous. And when I say preventive, I'm not just talking about screening mammography or flu shots or primary prevention. I'm really talking about ongoing prevention in terms of persons with established illness and disability, what we talk about as tertiary or quaternary prevention. And much of this is because of the limitations of office-based practice. Persons with disability, and as Chris said, we define that quite broadly, individuals who are unable to meet their ADL and IADL needs independently, whether it be by virtue of physical disability, chronic mental illness, aging and frailty, multimorbid medical conditions, all compounded by the financial and social barriers to health. Persons with disability live with that condition continuously. So there's a mismatch between their experience and the way that we have designed and organized care. We've designed and organized care around the provider, really not around the patient or the consumer. And really, the challenge of fully integrated care is to match care to the individual. Care is also fragmented, and it's fragmented in many different ways. Typically, in persons with complex medical situations have a different provider for every organ system, for every problem on their problem list. And there's very little coordination among different providers. Furthermore, it's cumbersome and burdensome for individuals with disability to access the care in that way. There's also fragmentation along and across the continuum of care. We have hospitalists, we have SNFists, we now have transitionalists, we have palliative care consultants. And as an individual moves along the continuum of care, there is a change in provider at each stop along the way. There's also fragmentation between disciplines, and not just between medicine and nursing, or between medicine and behavioral health, or between medicine and rehabilitation disciplines. But perhaps even more important for individuals with disability, there's fragmentation between the direct care workers, who are often doing most of the hands-on care and support of individuals with disability, and the so-called professionals in our interdisciplinary teams. Care tends to be standardized and uniform. We have a tendency to want to bucket patients into bucket where you get this package of care, when what we really want to be asking is, how can we titrate care in small increments so it is individualized and fully person-centered? So these problems, the reactivity and episodic nature of care, the fragmented nature of care, the difficulty with accessing care, our difficulty in titrating and individualizing, all this results in preventable, avoidable costs, misaligned incentives, and often failure to access primary care. In terms of misaligned incentives, as you're well aware, in fee-for-service medicine, everyone tends to benefit from the churn, the referrals to specialists, the referrals for tests, the follow-up appointments in perpetuity. Everyone benefits except for the patient, because the system of care is structured and organized around the providers often, rather than around the individual. And again, just to restate the challenge for us, the challenge really is, with the opportunity of fully integrated care, how do we restructure it so that it really focuses around the individual with the disability? Next slide. So when we talk about disability competent care, what do we mean? It's a person-centered model delivered by an interdisciplinary team that focuses on achieving and supporting maximum function, independence, to maintain health, wellness, and life in the community, that recognizes and treats each individual as a whole person, not as a diagnosis or condition, and structured to respond to the physical and clinical needs while considering also emotional, social, intellectual, and spiritual needs. So a very broad-based, holistic definition of health that very much aligns with the World Health Organization definition of health. Not just an absence of illness and infirmity, but overall well-being. Next slide. So here we have a contrast between the traditional medical model and the DCC model. Obviously, the medical model focuses on medical problems, often broken down by different problems, where we're really focused on the individual and the person. In the DCC approach, what we want to do is remove barriers that create problems with access and grant the consumer control over services, options, and the care plan itself. One of the ways of changing our thinking about that is to really think of the individual as a consumer. One of the reasons that we have embraced consumer-directed personal care, both in our PACE program and in our Senior Care Options program, is that it really reorients and changes the mindset of the providers, of the professionals on the team. If the direct care is consumer-directed, then why not the entire care plan? And it shifts us from what we want to achieve as outcomes in a care plan to what the consumer wants to achieve. What are his or her goals? And they may not be medically focused or oriented. They may be much more broadly defined. So it shifts our focus and orientation. And therefore, the locus of control shifts, and we have to relinquish control. But what we learn is by doing that, we actually gain more authority even in the long term. Next slide. So these are the core values of the disability competent care model. As we talked about, participant-centered, person-centered. It elevates autonomy to the primary ethical principle, respecting participant choice and the dignity of risk. We'll have a whole session on the dignity of risk. But really, disability competent care means shifting from us worrying about what risks we can live with to what risks the consumer wants to live with. We try to change from the institutional paradigm to a person-centered paradigm, removing medical and institutional bias. And as Chris said, the 3 pillars of competency are relational care coordination, responsive primary care, and flexible long-term supports and services. Next slide. By relational care coordination, what we really mean is developing a relationship. And of course, it's important to have a good working relationship with one's primary care providers. But that's usually insufficient for persons living with disability because those interactions, again, are intermittent and punctuated. For someone living with a disability in an ongoing, continuous manner, you need ongoing and continuous relationship. You need someone with boots on the ground in the community where participants live, where consumers live, and in their home and familiar with their environment, developing a relationship with them. Next slide. Primary care needs to sort of change its orientation to become more responsive. And the most important example of that is the same-day sick response. If someone has an issue, it can't necessarily wait until the next available appointment. There need to be a multiplicity of ways to address that problem that day. There needs to be a capacity for home visiting. There needs to be transportation available if necessary, to transport an individual to access care. There must be urgent care capacity. And all of that must be done with a sensitivity and awareness of the disability that the individual is living with and the barriers to care that must be overcome. Next slide. And finally, flexibility and long-term supports and services. Again, as I spoke about earlier, we need to move from sort of a bucket mentality to an individualized approach where services are titrated to meet the needs of the individual, where they can be modified with any change in status, where they truly become flexible to meet the changing and ongoing needs of the individual. Next slide. So this diagram sort of illustrates this notion of titrating the intensity of care to the need of the individual. And even though here we have bucketed it into high care, medium care needs, and low care needs, I like to think more of it as a continuous rather than a bucketed approach. So you can change the care you deliver, change the supports and services as one's need changes. Next slide. So at this point, I'm going to turn it back to Chris, and hopefully we'll have time for questions at the end.
Jesse, would you actually go back to the last slide? I really liked Adam's point on that last slide with the inverted triangles. I think the slide does kind of imply that we put someone in a bucket and that's where they stay. And I think however the model is applied, there needs to be a flexibility to what's going on with Sally today. So today she may have high needs because she's in a serious episode subsequent to a UTI. But tomorrow she may be, not tomorrow, next week she may be just fine, may go down to low care need because she's totally on her own. So I think I think his clarification there is a really good one. It's a really helpful one. So Jesse, have you put up the third slide? I think it would be good, the third polling question. The last polling question, it was interesting that the majority of people were care coordinators. And now this polling question is, when considering your own organization, which of the pillars that Dr. Ed Burrows described do you think presents the greatest opportunity for improvement? The participant-centered care coordination, the primary care, flexible LTSS, all the above, or none? Be interested in participants' response. I mentioned earlier on, and there was a slide in this packet here that talked about the DCAT tool. There's a reference to that at the end. I don't know that we need to go over the slide again, but what that tool does is it basically breaks down all that Dr. Burrows presented in far greater detail and asks you, kind of takes you through a whole process of looking at your own organization, your own organization's capacity and capability. It then kind of kicks it out into where are the opportunities, and then gives you kind of a strategy for how do you prioritize those opportunities, what are like low-hanging fruit, and what are things that are going to be really important but are going to take a year to be able to get to full implementation. And it's really kind of a whole QI process, and I think the tool is a good starting point for really most any organization who's beginning to serve this population in significant numbers. So at this point, I think we can open it up to questions. So if the operator could come back on, I'd appreciate it.
Thank you. Ladies and gentlemen, if you wish to ask a question, please press star followed by the 0, and an AT&T operator will assist you and give you further instructions. Once again, for questions, please press star 0 at this time.
Okay, until we get some questions in, I have a question or two that I'm going to ask Dr. Burrow. How does care coordination for persons with disabilities vary from care coordination for other populations?
Well, I think for other populations that may have episodic care coordination needs, they have an episode of illness, and they may need some support in addressing that issue. I think the most important concept is that persons with disability are living with that continuously. So the person charged with care coordination has to establish, as we talked about, a relationship with the individual continuous over time. I would also argue that care coordination really cannot be provided remotely, exclusively remotely, telephonic or office-based. It really needs to be based on an awareness of the individual's living environment, individual social environment, the financial and social barriers to health that individual is living with on a day-to-day basis. So I think, really two things distinguish it, perhaps. One, its ongoing continuous nature in building that relational care coordination, and also the greater complexity, which requires a better understanding and familiarity with what the living experience is of that individual.
Thank you. I appreciate that perspective. We received a call or a question from Kathy Kaufman. She says, I don't think anyone on the line disagrees with the strategy. But tell me, and this is what I hear from plans across the country, tell me how to engage the physician practice model of episodic care coordination. In other words, how do plans get their providers, especially on the primary care side, to be able to implement this model without absolutely overwhelming them with the needs and expectations?
We're going to devote a whole session to primary care. But I'll say this at this point, and this is a point I've made before and will continue to make, is that plans have to start to think of themselves as providers if they are going to engage with these populations and these individuals. And it needs to be the plans as providers that need to carry a lot of this competency to the primary care practice. I don't really think that we can fully expect primary care practices to transform themselves overnight, to be able to accommodate persons with disability in the way that we would ideally like them to. They have constraints themselves. But if the plan is assuming responsibility for individuals with disability, the plans themselves have to assume responsibility for that competency by putting clinicians on the ground in the homes and carrying that to the practices.
Great.
In other words, the ownership of it really has to be with the plan thinking as a provider.
And, there's a variety of strategies that have been used across the country. I think we've actually asked Adam in a future webinar here to talk about some of those approaches, because they really, you need to assess where your members are, what practices are working well. One question we had is, when I did a comparable program in Minnesota, is could we find a physician champion in a practice? If we found a physician champion, he or she was really able to kind of get that practice to begin thinking and functioning a little differently. So there's no textbook or answer to that question. I think this is something you need to work with, and as Adam said, the plan needs to own that, and then support that by providing the plan, obviously, with data and adequate reimbursement, which is, of course, a whole other issue. Tom, are there any questions online?
That's queued up on the phone lines. I'll give another quick reminder. For questions, please press *0.
Okay. Jesse, can you put up the poll results from the last question? So it's interesting. The majority of people on this call, the pillar they most worked with was care coordination. But really everyone says it's very interesting. But people are overwhelmingly say that it's all the above that needs to be looked at, and I think that I'm really pleased to hear that, because working in isolation, as we all know, doesn't get at the systems changes that not only we know is needed and that our regulators are expecting, but that our members desperately need, because these are usually the people who are not getting the care they need, when they need it, and how they need it. Another question I have heard is, quote, I'm still confused about what is considered a disability. For example, are those of us with poor eyesight disabled? Let me take a shot at that, and then Dr. Burrow, I'd be interested in your response. I think I would encourage you to stop thinking about it as disability and an individual as disability, and instead think about, are they functionally impaired? If they can't see to be around in the community, they are disabled by poor eyesight. If they need to wear glasses, but with glasses they can read 12 points, they probably aren't functionally impaired. So I think what this medicalization has done over the years is people tend to look at disability in terms of diagnoses, and this whole model is built on looking at disability in terms of function, and how can we support these people to function in a community setting for lives that they want. Dr. Burrow, how would you answer that question?
Well, the way I think about it as a geriatrician, I think about one's ability to independently perform ADLs, activities of daily living, basic ADLs, and IADLs, those instrumental activities of daily living that one needs to do in addition to basic ADLs to survive out in the world. And then through assessment, determine how one is doing with each of those basic ADLs and each of those IADLs. And then determine what are the impairments, what are the obstacles and barriers that may cause one not to be able to function independently in a particular domain. What can we do to improve function so that one can be as independent as possible? When someone is unable to achieve independence, what long-term supports and services could be put in place to make sure those ADL and IADL needs are met? And my experience is in the population I serve, it's really one impairment contributing to an ADL or IADL disability. It's usually a multiple impairments across cognitive domains, physical domains, social and behavioral domains, which is why in addressing them, you need to bring the interdisciplinary team to bear on both improving independence and supporting ADL needs when they cannot be met. And as we talked about before, long-term supports and services need to be flexible. So one's level of independence and one's need for support changes over time. So there needs to be both continuous assessment, continuous engagement with the individual to know if there's been a change in status and a change in need, as well as the flexibility to respond to it so one can remain living in the least restrictive setting possible, at home in the community ideally, having all ADL and IADL needs met.
Here's a question from Montrose, who I happen to know is from Colorado, and they have an interesting model of managed care. The disability competent care model still seems to imply medicalized care done to persons with disabilities by professionals, rather than a balanced approach to training, empowering, supporting, self-care, breaking dependence, and non-accessible, non-disability competent care providers. Adam, do you want to take a shot at that first, and then I'll go at it too.
Sure, I was hoping you'd take the first crack, but I think our conception of disability competent care, the DCC model, is trying to move us away from an overly medicalized and overly professionalized model. I think there's a recognition that in the approach we're endorsing, we want to change the locus of control to the individual, so the individual controls resources, controls direct care, and hopefully by extension more aspects of their care. But there also is a recognition that that individual needs to engage with the larger healthcare delivery system in order to address medical problems and other issues. And so, how do we bridge those two? How do we bridge the experience of the individual, granting control to the individual, creating a person-centered approach to care? How do we bridge that with the healthcare world around us? And how do we influence the healthcare delivery world as it's been structured to be responsive to that and to accommodate that?
I like that approach, Amanda. Your comments make total sense to me. We are transitioning, and it's not just the care and service and support for persons with disabilities. I think it's kind of across the healthcare continuum. I think in this world in particular, the problem that we're dealing with now is the dollars have come out of medical dollars. And so now we're trying to use medical dollars, and we're throwing in Colorado especially, it's an interesting model, because you're throwing in a lot of social dollars and community support dollars and so on. But historically it's been medical dollars. So we're trying to, you need to use some of the language in the medical world in order to access some of those dollars and to get those providers involved. But we need to kind of translate that to more independence. I think your language was self-care, breaking down dependence. One approach that I know that we talked about with you in particular, Gary, is training. The training that can be done for providers around disability competency. And it's not so much about how to deliver disability competency, it's really more of a mindset and how do you look at it and how do you elicit from the individual what is important to them. And that's clearly something that needs to be done. But the question is I don't know that we can start there. We need to keep our eyes on it, but it's going to take some time to get there. So push back in your question if you have anything more you want to say on that. Then there's another question from Mary Martin, who I believe is in Minnesota. Her question is, health plans don't usually fund LTSS. And I think that varies across the country. I think there's some dual plans that do incorporate long-term service and support. Some dual plans don't. And it really boils down to the state. But I think the majority of them don't incorporate it. Or if they do incorporate it, they only incorporate a portion. Like in Massachusetts, they do not, the under 65 do not incorporate PCA. So the question then becomes, if health plans don't fund LTSS, how do we suggest that they better utilize them? How do they influence the support that is needed for the person to maximize their functioning, maximize their life as they want to live it, and minimize their avoidable episodes of illness, such as skin breakdown and so on. And I think that's a tough thing. I think ultimately that boils down to the relationship issue. And so I would suggest with any plan, you need to partner with whoever is responsible for that. I know in Massachusetts, they contract with Centers for Independent Living to do that. So then the issue becomes, and maybe Adam, you can talk about this in Massachusetts a little in a minute, but in some states, local counties do it, and in which case the plan needs to develop good relations with the counties so they can call County A and say, I've got Sally here, she's coming out of the hospital. She can go right back home, but she would need to increase her PCA services from 4 hours a day to 12 hours a day for 2 weeks, or else she's going to end up in a nursing home. Well, that needs to be done, obviously, pretty quickly, and that can only happen with a relationship with the entity who's responsible for that services. So I think all I can do is suggest to build and keep those relationships with those entities who do have the capacity to respond and fund the LTSS services.
Yeah, I agree. I mean, if we acknowledge that the most critical element in the health and well-being of an individual with disability is his or her long-term supports and services, and that health outcomes and health utilization and health costs are dependent most upon the success of those long-term supports and services. we cannot disengage from them, whether we are responsible for their costs or not. We're obliged to engage with it. We're obliged to engage with it in a way that recognizes consumer direction and control where that exists, but nonetheless, we must engage with it. Otherwise, we will never be able to address the social and functional determinants of health. Ideally, it's fully integrated, and when I think about integrated care, I'm thinking about fully integrated care with long-term supports and services included. But if there are situations where that doesn't exist, it just imposes upon the health plan an additional responsibility to develop those relationships and become fully engaged with that world.
Again, it's back to the question from Gary. It's about process, and I mean we're in an evolution, and it's in process. Dr. Burrows, I don't know how familiar you are with the OneCare programs in Massachusetts, but how are they bridging that gap between the external entities who are doing LTSS and the care teams that are within the plans?
I can speak more about the Senior Care Options Program than about OneCare because I'm more intimately involved with that.
Yes.
In Senior Care Options, sort of the vehicle for bridging that is someone that we call a Geriatric Support Service Coordinator, who is our link to the Aging Service Access Point, the Area Agency on Aging world. So that individual functions as a linchpin between our world and theirs. Similarly, in the OneCare program, whether it's with whatever agency we're doing that, we're establishing that relationship. And, that's one of the interfaces that we have to address, where we have to have a mutually respectful relationship, understand that the orientation may be slightly different between them and us, but nonetheless, we have to work together to develop engagement, collaboration, and work together on behalf of the individual, serving the individual's needs and goals.
Great. Other question that we've gotten online here is, and I think this is probably, there's a couple of things going. When working with a person with disability, what's expected of the care team, however it's formulated, in terms of accommodations? There's two answers to that. One is the legal answer, which is obviously to meet the ADA and other requirements. But really what I would encourage to step back and encourage everyone to not so much look at the legal implications, even though they're certainly very important, but to say, what does this person need and how can we get it accomplished? If the barrier to getting the person back home is a ramp, then you have to figure out how to get the ramp. If there isn't funds to pay for the ramp, then you need to step back and think, oh, is this person involved in the church? Could some volunteers from the church build the ramp for the house? That's the kind of mindset that I think all of these programs are being challenged to kind of step back to is what does this person need and how can we meet that need? How can we accommodate that need and respond to it based upon the prioritization of the individual? And so I think what's happened in the past is we look at, well, what are they qualified for? What is the benefit that we can, with this diagnosis and this ADL dependency, they qualify for this. Someone with an ADL dependency of 7 may qualify for 6.3 hours of PCA, but they have a very functional home living situation. They may only need 3 hours. But another person with the identical score may have a very problematic home situation, unreliable caregiving, and so on, in which case they may need more. And I think what this population, and all populations debatably, are asking for is the engagement to discuss what I need and how I can get that need met. And I think that's why the first step is getting to know the individual and the context in which they function and the sense of who they are. That will then get you to looking at how can we best accommodate their needs. Tom, are there any questions before I begin to wrap this up?
We did have one queue up, and it's from the line of Victoria Haltom. Please go ahead.
Hi, this is Victoria Haltom. I'm from Michigan, and I'm a social worker. In Michigan, we are linking Medicare and Medicaid together under a program called Michigan Health Link. Very similar to PACE, but if you're in PACE, you can't be in Michigan Health Link, obviously. Yeah. My concern is that each person is going to be assigned a case coordinator, and right now we don't have any outlets for an ombudsman or any way to straighten out problems with the program. And the other thing is we have not been told how many people will be on a case, but if it's like our Department of Human Services, they have an average of 400 people. And I'm very concerned about it's so comprehensive that it sounds like a miracle of all the things that they're going to be able to do under this new program. And I have worked with PACE too. So I think it's a great idea coordinating all this. I just really am concerned about how it actually comes off in practice.
That's ultimately the key question. Adam, do you want to take a shot at it in some of your experiences? Then I can talk a bit about some things I've seen.
Well, since you referenced PACE, I'll start with my PACE experience. Yeah. As you probably know, the unit of care management, the unit of care coordination in PACE is the team itself. There's no individual charged with that particular function. So, in this model you described where, I guess, a care coordinator, I think you mentioned, might have a very large caseload, if I understand your question correctly.
Yeah.
The question then becomes, with whom is that case coordinator working? What is the team that the health plan is assembling to actually deliver care? And the hope is that individual won't be working in isolation. You really have to build teams to do the multidimensional continuous assessment and to deliver the interdisciplinary care. And, if you're talking about a model where primary care is remote, then bridging to the primary care site and carrying some of that disability competency, owning it and bringing it to the primary care site. So, yeah, I would be concerned if the model is expecting a lone care coordinator to carry a caseload of 400 and manage everything. There has to be a team behind that in interdisciplinary team care.
Thank you.
I was just talking with a plan this morning that was saying that in that state they are expected to do an assessment with the physician for every member in their dual plan every 6 months. That works when you have, they have 300 members at this point. There's low enrollment. But when you get to large numbers, that's not going to work. In California, I know that the plans have a tool. They use a tool to begin screening who do we need to call first. If you're getting enrollment of 500, 1,000, 5,000 at a month, you just don't have the staff. So you got to somehow figure out who are we going to connect with first. Ultimately, it becomes a question of, and I like this thing out of another plan that I've heard. It becomes a question of what does this member need and how can you be responsive. What this one plan came up with, though it's been a little problematic to implement, is that at the end of the initial assessment, they engage with the person saying, so what do you want? What do you want of us, and how much interaction do you want with us? They have found that the members are often among the best indicators of what they want. Some people with very complex needs, maybe even on a ventilator, they just want you to get out of their way, and they'll call you if they need something, and they may be doing just fine. Whereas someone may be live with paraplegia, and have some other problems going on, they may need a lot of hand-holding and coaching. So you need to be able to, A, have that discussion, and then, B, have a way to link Sally with the level of care coordination that she needs up to the staffing that's available. This organization I'm thinking of basically found that 40% of their members were in the what they called "you call us when you need us" category, and that worked very well. Then they have the high need category who just need regular phone contact and maybe a monthly visit. and then there's in between, and then there's an urgent need. And that's what Dr. Burrows was talking about earlier. There's an episode of illness coming up. You need to make sure that you have a staff available that day to respond to that episode, or else the person's going to be in the hospital or have significant issues. So I think some plans are hoping to do some medication reviews or history of hospitalizations and that kind of thing. Those really diagnoses, those are fairly unidimensional and don't really get at the kind of care coordination Sally, the individual, that's my euphemism for an individual, that Sally may need. And so I think the real art is the organization setting up the capacity to engage with the member and to be flexible enough to respond to episodes that may occur in that member's life. So with that, I think there's no other questions that were submitted online. So I'm going to begin moving this, in closing this. We very much like to thank you and appreciate your taking a minute to this hour to participate in the webinar here. As I said, the webinar will be posted online shortly. We hope you will consider the other webinars that are coming up in future weeks. I did want to point out that we've had a schedule change. So those of you who signed up for the entire webinar series, the session titled Integrating Behavioral Health Competency within Disability Competent Care Teams will be in week 3. So that will be held on Wednesday, May 20th. And the Dignity of Risk webinar will be, we're still trying to finalize that date, that will be in either the 3rd or the 10th of June. So if you're particularly interested in the behavioral health and primary care integration, please note that that will be 2 weeks from today. Next week, we're going to be focusing on understanding the lived experience of disability, and the presenters will be June Isaacson-Kales, who's done a lot of training for 20-plus years, and a gentleman named Dennis Heafy, who is one of the leaders in the disability advocacy community in Massachusetts that has really guided the development of the One Care program, which was the first demo that got up and running in the country for those under 65. So the two of them will present, and they will talk about their own experiences and go from there. So appreciate your time at the end of this for taking a minute to complete the survey that is, if it's not up now, it will. There'll be a link to it shortly. There it is. And I also wanted to thank Dr. Burrows for his presentation today. You'll be hearing from him 2 further times. I think his on-the-street experience, both through PACE as well as Commonwealth Care Alliance, is phenomenal. And I think he brings a breadth of a way to step back and really look at how do you begin going at this, because we're talking systems change. And even with the best ideas and the best intentions, it evolves. So thank you, Dr. Burrows, and thanks everyone else, and we'll look forward to future weeks.
Ladies and gentlemen, that does conclude our conference for today. We thank you for your participation in using the AT&T Executive Teleconference. You may now disconnect.